who'd had long recalcitrant pain in his low back. He has actually had, which you can't see, a disc replacement. It's sitting at the front here. And why this was so useful is we couldn't MRI this section because we couldn't shut down the artifact that was blocking. What he has in fact happened, probably I'm afraid as a result of being jacked open again by the disc replacement, he's had a pars fracture at the back. But this was almost impossible to image before now, and again you can see on this one here that the pars defect is difficult to see. It's a little bit easier there, but until it moves, which I'm hoping it will. No, they're not going to do it. It's not okay. Here we go. This is the nice image now. This is the full picture. There is the disc replacement. You can see it's a very wide interspace there. He actually had a very degenerative L5-S1 disc where the surgical intervention has obviously gaped that open, distracted the facet joint, and due to the change in dynamics, he's had a fracture at the back. And if we just show, you can see it actually moving. Just there. It's quite a big deflection. So what are the results of all this? Well, I'm proud to say that because, necks are just my specialty really, but in a predominantly neurosurgical unit, we've actually managed to reduce the amount of neck surgery that we had been referred to us by up to 85%, which is quite a big result. Most necks and lumbar spines are usually operated on far too early, and this is what we're trying to prove. If you can restore the function, very often the structural anatomy really doesn't matter. And it's amazing what the body will put up with in distorted anatomy. It will adapt. And so function is everything. Sorry. So just the take-home message really is a bit more of a joke really. Dynamic people thinking in dynamic ways about dynamic imaging and dynamic treatment. And hopefully we get dynamic answers. Thanks very much.
Thank you very much, Nick. As you can see, it's a real challenge when you've got something as simple as neck pain, working out all that physiology, that anatomy, and how we fit in our imaging tool to provide the best answer. And we're always striving for the next best thing. And it has been quite enlightening for me to see how we can actually help that. But, as I say, as you can probably understand, I learn as much from working with people like Nick as I do surgeons. So it's a tough job for all of us to work together, but it's critical to getting these things right. Now, we're going to finish now with a good friend of mine, Brian English, who's going to come and talk to us with his laptop. I'll move to one side. You had a bit of a torturous journey, haven't you, Brian?
Started yesterday.
Yeah. I mean, he's made a real effort to get here, and I'm very grateful that he has come along to tell us about his experiences of managing football injuries at Chelsea Football Club. It says here, Brian, separating fact from fiction.
That was your title, Frank.
That was my title, okay. Yeah. Do you have another one?
No, that'll do.
That'll do. Okay, good. Thanks, Brian.
No, while we're setting up, I'm sure you not particularly bothered about hearing about my journey over the last day or so, but it's going to fill the gap whilst we're setting up here, so I'm going to tell you anyway. Yesterday, leaving Heathrow for the 9 o'clock to go to Munich. There was a bit of fog, so I ended up getting to Munich at 6 o'clock, so I couldn't get the plane back, which was delayed furthermore, getting me back today. But I mentioned Munich just because working in sport, learning from colleagues in different countries is something that we're used to doing in the medical profession, admittedly. But learning from German people with regards to the way that they practice their medicine, specifically musculoskeletal medicine, certainly taught me a lot, and also made me look a little bit more as well into the German literature, because if I may comment about the people in my particular specialty, that the English-speaking literature is one that we're sort of very familiar with, looking at the research that comes out of Australia and possibly Scandinavia and America. But the German literature is something that we don't look a great deal at, and they have done a lot of pretty dynamic work in musculoskeletal over last really going up to 50 years. So, my form of work, I need to have a close relationship with radiologists. In fact, probably closer relationship with radiologists than with any other profession or any other specialty aligned to sports medicine. Days off work, I mean, sometimes when I talk about this, I mean, this doesn't look particularly important, does it really, when people are in specialties such as our previous speaker, when you're talking about relieving somebody's neck pain, replacing discs in the neck. You know, at an undergraduate level, well, how important really is a hamstring tear or a gastrocsoleus tear? Well, of course, to us, it is extremely important, and the difference between back in 17 and 21 days is very important to us, because it may mean another game, and it may mean a victory, it may mean a lot of money, and in some cases may mean you're keeping your job or not. Just out of interest, what do you think is the most common of those injuries, the most common cause for days off work in professional football? I'll answer that at the end. Fascial injuries in football. Again, I'd worked in several sports before I worked in football, and a muscle injury is a muscle injury, is it not? Well, to us, again, it is not, and specific reasons for that. Because a fascial injury in a sport such as football, and if the radiologists are telling me that this is a fascial injury, makes me quite happy, because it goes with the kind of history that is specific to either getting a fascial injury in the muscle or a true contractile tissue injury. So a subtle history can point in towards that particular direction, and the most important thing for me there is return to sport. With a muscle injury, you're back in about 17 days, and a fascial injury, you're back in 11 days. So you can encourage the people that you are working with that you can go a bit quicker if it's a fascial injury. You can get to a higher functional level within 48 hours, maybe, rather than 96, as it were, 2 days rather than 4 days. Get them to a higher functional level, and therefore you get them back quicker. The pressure on us is to get people back as soon as we can, and we would view it as a failure if they get a recurrence of that injury within 6 weeks of them sending back, or of course during the rehabilitation process. If we get them back nice and quickly, and we have Champions League audit to compare what we're like compared to other teams, and they don't get a recurrence, then we can give ourselves a pat on the back. You don't often get a pat on the back from other people in football, because if you have one person in the treatment room, that is viewed as one too many. There is still a bit of an adage out there that it can be the medical team that cause the injuries, whereas, of course, you know as I know, it's the coaches that cause the injuries. Ooh, controversial. So, again, these little feathery appearances of the fascial injuries, great for us to see. I mean, I think we could do some of these, Simon, after a game, and we would probably see injuries such as this anyway. So we don't treat the scan. Of course, we do treat the player, but nice injuries to see. So that would be my summary of that. You might think I'm going a little bit quickly, but I realise some people in the audience will be thinking in 4 minutes' time England do kick off against France, and you may be a bit concerned about that. Therefore, for you, I'm just going a little bit faster than I normally would do. I just want to show this. This is a little bit away from radiology, but this was probably one of the more profound moments that I had working for this particular football club, and one where they should observe the rules of the game and apply them accordingly. This player that drops his knee into the side of that goalkeeper's head, by the way, fractures his skull. He ends up with 2 spikes of bone going into his brain, and he's out for many months. But you look at that on video, and that has to be worse than an Eric Cantona doing a kick at someone in the crowd. That needs to result in some kind of punishment rather than nothing. When you could have obviously permanently brain damaged that particular player by doing that form of tackle. It's interesting for me, and maybe all the radiologists know that here, that this particular player was susceptible to this type of injury because he was one of triplets, and that part of the skull is thinner in triplets and twins than it is in those who are not a twin or triplet. That was something that I did not know. But he continues to wear headgear, as I see that a player in Inter Milan, after suffering a skull fracture, also wears headgear now, and that's an outfield player. Young people in the United States are encouraged to wear headgear, and maybe it's something that we'll see more and more in the sport, and therefore we'd have to see less of this, where we have to end up imaging these people after the injury on neurosurgical units and treating them accordingly. What do we do about those people to get them back on the field of play? Well, I mean, imaging doesn't take us a great deal further, but we do have to assess these people from a neuropsychological point of view before they go. Interestingly, when we started doing that, by the way, we found out that all our footballers were above the average IQ for the general population. A couple of wry smiles in the audience potentially there. Now, I would wager that that is different compared to players that maybe play for other teams. And my theory being that to play at an elite level and to understand the intricacies of the tactics and to read the game in the way that some of these players do, I think you need to have a certain amount of intelligence. To put the ball on somebody's foot and predict where you want them to run to, not where they want to go themselves. It is for the truly elite people, they need to have a good and a quick brain. I throw this one in. This is in exactly the same game, so that was number 2 goalkeeper rendered unconscious. But again, foul play. Sonko comes up here, he's ducked his head down, he's using it like a battering ram, so again it's a weapon. No punishment during the game, no punishment afterwards. Only that keeper number 2 there kindly is lying on his back. Great, so when I go up to him you can manage him straight away. That's nice and convenient for him. But he was unconscious, but he left hospital that evening and was able to play once his neuropsych scores got back up to normal, as well as all the other aspects of treating a head injury. He was back in 2 weeks, whereas the other goalkeeper was conscious when I arrived, a little bit confused, a bit dazed and confused, but was talking to me, looking at me in the eyes, yet he was obviously substantially worse. So initial impressions when you get onto the pitch, if you haven't actually seen the mechanics of the injury, because you're down in a dugout, can be a little misleading. I hope this video works. Let's just see if it does, because it's not going to work. Never mind. Right, this is the last one of the head injuries. This was a cup final in Cardiff, and there's the impact. But again, the player's gone onto his back, which again makes recovery from the field of play quite. It's easier to start with because they're in a position where you can manage them. You may see, as in you did with Cudicini, that their arms start moving like this primitive reflex indicating to you as you're running onto the pitch that he's had a bit of a stretch to his brain stem. And when a player is like this, now, this is what I wanted to say, you see what's happened to his neck and you see the way he's been managed by the players, and a member of the medical staff from the opposition comes on and doesn't do a much better job. Now, the only reason why I wanted to say that is that part of the management on the field of play is educating the players about what they should and should not do, and obviously in that situation is leave them alone, we're only a few seconds away. But also educating people that you work with, so we are all at the same level. And following that incident, England now, you have to do a 2-day course, and you have to pass it, otherwise you're not allowed to work in the Premier League on rescuing people from the field of play. So there's a certain standard of ability removing people from the field of play. The rest of Europe hasn't caught on with this yet, but at least now we have some standards, so your player is going to be looked after if the opposition person is there early, which is very unusual. He just happened to be behind the goal at the same time. But especially when there's a lot of people watching and there's video evidence there, it's good to know what you're doing when you're managing these kind of problems. You know what? I'm really going to skip through this bit extremely quickly, but just in case you wonder what it is that we do in football, because I have that question asked to me many times, is that prevention is very important for us to prevent the injuries occurring in the first place, because the pressure is on you when injuries occur, because they will always come to you asking you, why is this player injured? And depending on your relationship with the manager, depends how much you can discuss it with the manager. Well, maybe after that particular game, you know, you doing a 90-minute very hard training session was maybe not wise, and they should have done a recovery session. So it depends what your relationship with the manager is like. But with more technology that has come in to assess the players, then you are able to give the feedback, look, this player is going into fatigue, he's not performing as well in games, because you can monitor them in training and games, see what their heart rate response is to a measured activity.